Imagine this. You're called to consult on a patient. They present with acute microangiopathic hemolytic anemia and severe thrombocytopenia. Your mind immediately races. Is this thrombocytopenic purpura or ATTP?
Mm-hmm.
And here's the critical question, really. Before those definitive 80-13 results even return, could adding a new targeted therapy like Caplacizumab be the difference between life and, well, devastating organ damage? Or even worse?
It's a scenario we all dread, frankly.
Exactly. Historically, ATTP has been a truly terrifying diagnosis. I mean, left untreated, we're talking about a shocking 90% mortality rate. 90%.
Unbelievable, right?
And even with traditional plasma exchange, PECs, and, aggressive immunosuppression, that mortality rate still hovers somewhere between 7% and 25%.
Still far too high.
It's just a relentless race against time, isn't it, where every single hour counts to prevent irreversible consequences to vital organs like the brain, the heart, kidneys.
This is precisely why Caplacizumab has emerged as such a, well, groundbreaking addition to our therapeutic arsenal. Its unique mechanism of action is what truly sets it apart.
How so? Exactly.
Well, instead of merely replacing a deficient enzyme, which is essentially what PECs aims to do, Caplacizumab is different. It's a humanized, single-variable domain nanobody.
A nanobody, okay.
Yeah, and this means it directly targets a specific part, the A1 domain of von Willebrand factor, or VWF.
Ah, the VWF.
Right. By doing so, it actively inhibits the interaction between VWF and platelets. And that interaction is absolutely crucial because it directly prevents the formation of those harmful microvascular thrombi that cause so much damage in ATTP. It disrupts the very process driving the disease's acute pathology.
So it stops the clot formation at a key point.
Precisely. Now, many clinicians are familiar with the foundational clinical trials, HERCULES and TITAN, which initially demonstrated Caplacizumab's efficacy. They were pivotal, certainly, no question.
Yeah, they made big waves.
They did. But what's fascinating now is how we've moved beyond those, shall we say, controlled environments. This deep dive is all about the rich, complex tapestry of real-world data that has emerged since those trials.
Right, the messy reality.
Exactly. And this isn't just about confirming prior findings, it's genuinely shaping how clinicians practice, offering insights that controlled trials, just by their very nature, can't always capture. This is where the theoretical becomes practical for you, the clinician on the front lines, navigating the day-to-day complexities of patient care.
Okay, let's unpack this then. For this deep dive, we've pulled together a stack of, 20 real-world studies?
That's right, 20 studies.
Think of them as snapshots from clinics and hospitals all around the globe, showing us how Caplacizumab is truly performing in the diverse, often messy landscape of actual patient care. These aren't pristine, perfectly controlled settings. They are the real world of medicine.
And what's compelling is the sheer variety of data we're looking at here. These aren't just your standard randomized controlled trials, your RCTs.
No, much broader.
Much broader. We're synthesizing information from retrospective cohorts, which look back at patient data. Large multi-center registries that collect information across many hospitals, pharmacovigilance reports tracking drug safety post-market, and even compassionate use programs where the drug was made available before full approval in some cases.
So a real mix.
A real mix. This variety gives us a comprehensive, nuanced picture, showing Caplacizumab's impact across different healthcare systems with varying protocols and, importantly, diverse patient populations.
And it's global data too, right?
Absolutely. This global perspective helps us understand regional variations in practice patterns and patient characteristics. We've gathered data from the UK, the US, Canada, France, Germany, Spain, Italy, Greece. Quite a spread.
Okay.
And within these studies, some include both new onset and relapsed ATTP patients. Others focus on specific ADAMTS13 activity levels at baseline. Some compare Caplacizumab use with and without traditional plasma exchange, or different immunosuppressive regimens, rituximab, steroids, you name it.
So lots of different angles.
Exactly. This multifaceted approach provides a really rich context for understanding the drug's utility and how it fits into the complex reality of clinical practice for you.
Right. So let's dive into one of the most critical aspects, time to response. One of the most immediate goals in ATTP is getting those platelet counts back up, right? You want that rapid response to halt organ damage.
Absolutely critical.
So what are we seeing in the real world when it comes to platelet recovery with Caplacizumab? Is it as fast as the trials suggested, or
The evidence is consistently compelling across multiple real-world cohorts. It seems caplacizumab dramatically accelerates platelet normalization.
how dramatically?
Well, for example, studies from the UK, Germany, and Italy consistently show median times to platelet normalization ranging from a remarkably fast 2 to 4 days.
2 to 4 days.
Yeah. And in Spain, one study found that initial caplacizumab use led to normalization in a median of 5 days. Now, compare that. That's a stark contrast to 15 days when the drug was delayed in that same cohort.
15 days versus 5. That's huge.
It's a massive difference. And remember, this isn't just about hitting a lab number. This rapid reversal of thrombocytopenia directly translates into a reduced risk of life-threatening bleeding and, crucially, signifies the resolution of that microvascular thrombosis, which is the core pathology of ATTP.
Stops the damage faster.
It means getting patients out of that critical danger zone significantly faster. For a clinician managing these often critically ill patients, this speed can truly be a game changer.
Yeah, I could see that. Now, for anyone who's managed ATTP, you know the immense burden of plasma exchange on the patient, on the healthcare system. Those daily sessions are grueling.
Incredibly burdensome.
Patients are tethered to machines for hours. It consumes massive hospital resources.
Mhm.
Does caplacizumab lighten that heavy load in the real world?
Absolutely. The real-world data unequivocally shows a significant reduction in both the duration and the number of PEC sessions required.
Okay, give us some numbers.
Sure. The UK study, for instance, found a median PECS duration of 7 days with caplacizumab, down from 9 days in their historical controls.
Okay, a couple of days less.
Right. But look at a U.S. study comparing frontline versus delayed caplacizumab initiation. They found a median of just 5 PEC sessions for frontline use compared to a whopping 12 for delayed initiation.
5 versus 12. That's more than double.
It's a massive difference. And even in Italy, where one center had protocols with a higher baseline number of PEC sessions anyway, they still saw a reduction. They went down to a median of 10 procedures from 16.5 in their historical cohort, and they directly attributed that reduction to caplacizumab.
So it helps even when the baseline is higher.
Exactly.
Okay.
And think about the implications. This isn't just about cost effectiveness, although we'll touch on that later. It's about reducing catheter-related complications, minimizing patient exposure to plasma products.
Big safety benefits there.
Huge. And practically freeing up those PECS machines and the highly trained staff needed to run them in busy hospitals, that's a major operational benefit too.
Makes sense. Okay, so while platelet recovery is rapid, what about the underlying autoimmune process? That's driven by the ADAMTS13 deficiency, right? Are we seeing faster ADAMTS13 normalization? And how does this all translate to a patient's overall time in the hospital, their ICU stay?
Right, that's a really important clarification to make. It's important to understand that caplacizumab's primary role is to inhibit the thrombosis, the clotting. It's not actually designed to directly accelerate ADAMTS13 recovery or clear those autoantibodies.
Oh, okay. So it manages the consequence, not the cause directly.
Precisely. Some studies note that ADAMTS13 normalization can still take several weeks. One Italian study reported a median of 33 days after caplacizumab initiation.
So still a fair wait for the enzyme levels.
Yes. And interestingly, one UK study even indicated that patients on caplacizumab might take longer to achieve ADAMTS13 activity above 30% compared to historical controls.
Longer. That seems counterintuitive.
It does, but notably, this did not translate to worse clinical outcomes. What this really highlights is that caplacizumab provides that critical bridge therapy. It protects the patient from the damaging clots, while the concurrent immunosuppressive regimen, the steroids, the rituximab, addresses the autoimmune root cause. It buys you the time needed for those other therapies to work effectively.
Okay, that makes sense. It's protecting the patient while the immune system is being treated.
Exactly. And despite the fact that caplacizumab doesn't directly speed up ADAMTS13 normalization, the downstream benefits on hospital stay are clear and consistently observed across studies.
So shorter stays overall.
Generally, yes. Hospital length of stay, or LOS, and ICU duration are typically reduced. That U.S. study we mentioned found frontline caplacizumab cut hospital stays from a median of 16 days down to just 9 days.
That's almost halving it.
Pretty dramatic. Similarly, Italian data showed a reduction in overall hospitalization from 22 days down to 12 days, and the median ICU stay was reduced from 4 days to 3 days. Now, it's not always statistically significant across every single cohort studied. There's some variability, but the trend is consistently and strongly towards shorter hospitalization.
And that means patients are getting home faster.
Exactly. Returning home or maybe to a less acute care setting much faster. And that's invaluable for their recovery, their quality of life, reducing hospital-acquired complications, all of it.
Absolutely. Okay, so beyond the immediate crisis management, the ultimate goal is durable remission, right? Preventing those dreaded early relapses or exacerbations. How effective is Caplacizumab in helping patients achieve and, crucially, sustain that remission? What are we seeing in the real world there?
Well, the real-world data certainly confirms high rates of achieving initial clinical remission. A Canadian study reported 91% of their caplacizumab-treated patients achieved remission. An Italian study noted 100% platelet normalization in their cohort. So that reflects the drug's consistent efficacy in rapidly controlling the microvascular thrombosis, getting the fire out, so to speak.
Okay, good initial control, but what about keeping it controlled? The durable remission and relapse prevention.
Right. This is where the picture gets a bit more complex and where some real-world nuances emerge. You might recall that early data from the TITAN trial initially raised some confusion, maybe even concern, about an increased relapse risk with caplacizumab.
Yes, I remember that discussion.
But that's largely been reevaluated. The issue was primarily definitional. Many of those events weren't true relapses long after stopping therapy, but rather exacerbations recurrences happening within 30 days of stopping PEX or caplacizumab.
Ah, so happening while the underlying disease might still be active.
Exactly. Often reflecting persistent underlying autoimmunity that hadn't yet been fully controlled by the concurrent immunosuppression. The core insight here really is that caplacizumab masterfully manages the acute thrombotic process, the immediate danger, but it doesn't and isn't expected to replace the need for robust immunosuppressive therapy to target the autoantibodies that are the fundamental cause of ATTP.
It handles the effect, but you still need something for the cause.
You've got it. It addresses the consequence, not the root cause itself.
Okay, so that leads perfectly into the next question.
Yeah.
What does this mean for concomitant therapies? We know steroids are standard, but what about rituximab? Are real-world studies giving us a clearer picture of how caplacizumab integrates with rituximab and the impact of that combination?
Yeah, it's a key practical point. All the studies consistently confirm caplacizumab is used in conjunction with plasma exchange and immunosuppression, primarily corticosteroids. That's standard.
Right.
But the role of rituximab, a potent B-cell depleting agent, is particularly emphasized in this real-world context. We see some interesting variability in practice.
That's so.
Well, some cohorts, like those reported from the UK and France, show very high rates of rituximab co-administration, up to 99 or even 100% in some centers using it frontline.
Okay, almost universal use there.
Almost universal. However, others, like an Italian single-center study we looked at, showed much lower rates, maybe around 30% receiving rituximab concurrently.
30% versus nearly 100%. That's a big difference in practice.
It is. And this variability raises a really important question for you managing these patients. Could the varying use of frontline rituximab explain differences we see in long-term outcomes, particularly those relapse or exacerbation rates?
Makes sense. Is there evidence for that?
Well, it's suggestive. The Italian study, the one with the lower rituximab usage, reported a higher relapse rate, around 30%. Now compare that to studies where rituximab use was more universal, where reported relapse rates were much lower, sometimes as low as 1 to 4%.
This is pretty compelling.
It strongly suggests that while caplacizumab is highly effective for tackling the acute thrombotic phase, comprehensive immunosuppression, potentially especially with early rituximab, is essential to effectively clear those 8-MTS13 autoantibodies and prevent future episodes.
So the combination is key for long-term success.
It seems that way. Caplacizumab controls the effect of the disease, the clotting. Robust immunosuppression addresses the cause, the autoimmunity. You likely need both for the best outcomes.
Right. Okay, let's shift gears slightly and talk about those really challenging patients, the ones who are critically ill on arrival, maybe a delayed diagnosis, severe organ involvement, or those who are refractory to initial standard treatment. Does caplacizumab still offer a benefit in these most difficult scenarios?
This is actually where caplacizumab truly shines in the real-world setting, based on this data.
Really? Even if it started late or in refractory cases?
Yes. Data from a Canadian study, for example, indicated that caplacizumab appeared effective and safe even when it was initiated relatively late. Their median was 6 days post-admission, or in patients who are already experiencing refractory disease. That group made up 45% of their Caplacizumab cohort.
So still helpful even then.
It appeared to be, and that U.S. study we keep mentioning really highlighted the significant benefits of frontline Caplacizumab, defined as starting within 2 days of the first PEX.
Right, the early versus delayed comparison.
Exactly. Patients who received it frontline had fewer TPE sessions, significantly shorter hospital stays, and remarkably lower overall inpatient costs compared to those where Caplacizumab initiation was delayed.
So a clear benefit to starting early.
A very clear benefit. And some data from the UK cohort explicitly showed a statistically significantly longer time from admission to starting Caplacizumab in those patients who ultimately died compared to those who survived.
Wow, that's sobering. Timing is critical.
It underscores a crucial real-world insight. The earlier you can get this drug on board, especially in patients with a high clinical suspicion of ATTP, the better the chances of rapidly controlling that microvascular thrombosis and improving outcomes. It really reinforces the idea that Caplacizumab should be considered a component of acute frontline therapy, not saved as a last resort for when things go wrong.
Got it. Frontline thinking is key. Now, any powerful drug comes with potential side effects. We have to talk about safety. Given Caplacizumab's mechanism of action, targeting von Willebrand factor, we'd naturally anticipate some bleeding risk.
It's inherent to how it works.
So what are the most common adverse events we're actually seeing in the real world? And how do they compare to what was anticipated from the trials?
You're right to anticipate bleeding as the primary concern, and that's largely what the real-world cohorts show. Thankfully, the side effect profile seems consistent and generally manageable.
What kind of bleeding typically?
The most common adverse events are typically mild to moderate mucocutaneous bleeding, so things like gum bleeding, nosebleeds, epistaxis, maybe some minor gastrointestinal bleeding like hemorrhoidal bleeding.
Okay, mostly nuisance bleeding.
Often, yes. A Spanish study reported some form of bleeding in about 20% of their Caplacizumab patients, with gum bleeding being the most frequent. These findings are largely consistent with what was observed in the pivotal clinical trials, so no major surprises there. It suggests a predictable and generally manageable side effect profile without significant unexpected bleeding patterns emerging in wider use.
Okay, that's reassuring for the common events. But what about serious bleeding? Are we seeing life-threatening hemorrhages, particularly in critical areas like the brain, that could negate the drug's benefits? That's the major worry, isn't it?
It is the major worry. And while serious bleeding events are observed, it's crucial to note they appear to be relatively rare in the context of this very sick patient population.
Oh, rare.
Well, a meta-analysis looking across several real-world studies showed that only about 2.3% of patients experienced severe bleeding.
Okay, low single digits.
Right. In the large UK cohort, 6% of patients had what was classified as severe bleeding complications. This included 2 cases of intracranial hemorrhage and 1 severe GI bleed.
Intracranial hemorrhage is obviously very serious.
Extremely serious. However, it's absolutely crucial to understand the context here. Often, the intracranial bleeds reported were described as secondary hemorrhages, bleeding occurring into an area of brain that had already suffered an ischemic insult, a stroke, from the TTP itself. Not necessarily primary bleeds directly and solely attributable to the Caplacizumab.
Ah, so bleeding into damaged tissue. That's different.
It's a critical distinction. Severe complications, including ischemic stroke and subsequent hemorrhagic transformation, can and do occur in severe ATTP patients, even without Caplacizumab treatment. The disease itself carries a high risk of both clotting and bleeding complications.
Right, the underlying disease is dangerous.
Exactly. So the overall consensus emerging from this comprehensive real-world data is that Caplacizumab does not appear to add a significant additional safety signal for severe, life-threatening bleeding beyond what is already expected and inherent in managing a critically ill ATTP patient population. You have to weigh the risk of bleeding against the very real risk of fatal or disabling thrombosis.
Okay, that context is vital. When bleeding does occur, maybe the more common minor or moderate kind, how is it typically managed in practice? Does it often lead to stopping the drug entirely, which we know could risk an exacerbation, or are there strategies to work through it?
That's a practical challenge. In many cases, the minor bleeding events we talked about, like gum bleeding or nosebleeds, often resolve spontaneously or with simple local measures.
Okay.
For more significant episodes, temporary interruption of caplacizumab is a common and often effective strategy reported in cohorts like the Spanish study. Often, pausing the drug for less than 48 hours allows the bleeding to subside before resuming treatment.
Just a brief pause.
Usually brief, yes. However, it's definitely a delicate balance and requires careful clinical judgment. We know that acute interruption of caplacizumab, even briefly, can potentially be associated with progressive microvascular thrombosis and disease exacerbation, so you have to weigh those risks carefully.
A tricky balancing act.
It is. And another interesting area of ongoing discussion highlighted by this real-world data is around thromboprophylaxis, preventing blood clots like DVTs or PEs.
Right. What are clinicians doing there? Are they still giving aspirin or other anticoagulants once platelet counts start to recover, say above 50,000?
Well, while some guidelines might recommend initiating antithrombotic therapy like low-dose aspirin once platelet counts recover, the real-world data suggests that concurrent caplacizumab therapy often leads clinicians, perhaps intuitively, to withhold aspirin or other anticoagulants, likely due to the perceived increased bleeding risk.
So caution prevails.
It seems so. There's no clear best practice defined here yet. Studies show that caplacizumab was sometimes interrupted in patients who developed a venous thromboembolism, like a DVT or PE, and needed full anticoagulation.
Where you might need to stop one to treat the other.
Exactly. It really calls for an individualized case-by-case approach, especially in patients who might have a pre-existing high bleeding risk or other strong indications for concurrent anticoagulation. It just demonstrates the complexities of real-world decision-making when you're juggling competing risks and benefits.
Absolutely. Okay, this deep dive has consistently highlighted that early intervention seems key in ATTP. But in the real world, things aren't always ideal. When are clinicians actually starting caplacizumab? Is it as soon as TTP is suspected based on clinical signs? Or are they often waiting for that definitive 8-MT-13 confirmation, which we know can sometimes take days? This timing could have a massive impact.
This is a vital question for you practicing on the ground. While the pivotal clinical trials like HERCULES initiated caplacizumab within 24 hours of the first PECs, the real-world data shows quite a bit more variability.
Delays happen.
Delays definitely happen. In the U.S. data we looked at, for instance, a substantial proportion of patients, 59%, received caplacizumab in what they termed a delayed manner. That meant 2 or more days after PECs had already started.
More than half starting late. Why the delay?
It was often attributed to logistical challenges, things like navigating prior authorization requirements from insurers, or simply delays in obtaining the ADAMTS-13 activity results if institutions waited for those before starting.
Practical hurdles.
Practical hurdles. However, despite these real-world logistical challenges, the data we have overwhelmingly supports the frontline approach. That U.S. study, again, clearly demonstrated that early frontline initiation within 2 days of TPE led to significantly better outcomes.
Remind us what those were.
Fewer PEC sessions needed, shorter hospital stays, and lower overall inpatient costs.
Okay, so the evidence strongly backs starting early.
It powerfully reinforces the expert consensus. Caplacizumab's benefit is greatest when it's given early, ideally based on high clinical suspicion, perhaps guided by a tool like the plasmic score, even before those definitive AMT-13 results come back.
Don't wait for the labs if the picture fits.
Essentially, yes, especially in severe presentations. The crucial takeaway for you and your institutions is probably to establish protocols that facilitate rapid access and administration once that high suspicion is there.
Right, streamlining the process. Okay, once caplacizumab is started, how long are patients typically staying on it in the real world? And what criteria are clinicians actually using to decide when to stop? Is it solely based on the drug label, that standard 30 days post-PECs? Or are other factors, particularly the resolution of the underlying autoimmune disease as measured by ADAMTS-13, coming into play?
That's another area where real-world practice seems to be evolving and showing some notable deviations from the fixed 30-day post-PECs duration used in the main clinical trials.
How so?
Well, in the UK cohort, the median duration of caplacizumab treatment was about 32 days, so close to the trial duration. But interestingly, 55% of patients actually discontinued it before the standard 30 days.
Why did they stop early?
Often because their ADAMTS-13 activity had already normalized, typically defined as being above 30 IUDL or maybe 20% depending on the assay. They felt the autoimmune driver was resolving.
Okay, using a biomarker to guide stopping.
Exactly, but conversely, 32% of patients in that same UK cohort continued it beyond 30 days.
Then why continue longer?
presumably because their ADAMTS13 activity hadn't yet recovered sufficiently, indicating ongoing autoimmune activity and a continued risk of thrombosis if the Caplacizumab shield was removed too early. Similarly, in Canada, the practice reported was often to continue Caplacizumab until ADAMTS13 activity was consistently above 10% or 20% and then rising, monitored weekly, or for other clinical reasons.
So much more individualized.
Exactly. This highlights a crucial evolution in practice. Instead of adhering strictly to a fixed duration, clinicians are increasingly tailoring Caplacizumab discontinuation based on monitoring the resolution of the underlying autoimmune process, typically guided by serial ADAMTS13 activity levels.
What's the general threshold people are using now?
The prevailing clinical approach seems to be moving towards continuing Caplacizumab until ADAMTS13 activity is consistently above 20% and clearly rising, ensuring the autoimmune phenomenon is truly resolving before stopping the drug. This individualized approach seems key to preventing those early recurrences or exacerbations and optimizing the treatment duration for each patient.
Makes sense to tailor it. Now, beyond the clinical data, real-world practice inevitably grapples with practical realities like drug cost and access. Caplacizumab, being a novel, targeted nanobody therapy, comes with a substantial price tag. What are the insights here regarding its cost-effectiveness in the real world, and what are the access challenges clinicians are facing?
Yeah, cost is undeniably a significant factor and a point of discussion. While Caplacizumab is clearly effective clinically based on everything we've discussed, its upfront cost can certainly be perceived as a barrier to widespread adoption in some systems.
It's not inexpensive.
It's not. However, that U.S. study provided a fascinating insight into the cost-effectiveness angle. It actually showed that using Caplacizumab frontline, despite its high drug cost, resulted in lower overall inpatient costs compared to delaying its initiation.
Lower overall costs. How does that work?
It seems counterintuitive, but it was primarily due to the significantly reduced need for expensive plasma exchange sessions and the shorter hospital stays that frontline use afforded. Fewer days in the hospital, especially the ICU, fewer PECS procedures. These savings apparently offset the drug cost in that analysis.
So the upfront investment potentially leads to downstream savings.
That's what that study suggested, yes. By preventing costly complications and avoiding prolonged, resource-intensive hospitalizations. It's a value proposition argument.
But are patients actually getting access easily?
Well, despite the potential for overall cost savings, logistical hurdles and access do remain a challenge in many jurisdictions. The Canadian experience, for example, noted that limited access protocols or reimbursement issues led to delayed initiation in some cases. Expert consensus reports also point to drug costs and the need for clear national guidelines and funding pathways as significant potential barriers to widespread uptake.
So it's not universally easy to get.
Not necessarily, no. It emphasizes that for Caplacizumab to truly transform ATTP management globally, efforts are needed beyond just demonstrating clinical efficacy. We need to address these access issues, streamline institutional protocols for rapid administration, and effectively communicate its long-term value proposition, including potential cost offsets to the broader healthcare system, payers, and administrators.
Right, the system needs to adapt. Okay, reflecting on all this real-world data, what are the big unknowns? Where are the gaps that these studies are highlighting? Where do we still need more information, especially thinking about those crucial long-term outcomes for patients who survive an ATTP episode? It's not just about getting them through the acute crisis, is it? It's about their quality of life years down the line.
You're absolutely right. Despite the wealth of real-world data we now have on the acute phase, significant gaps remain, particularly concerning long-term follow-up and tracking what happens after Caplacizumab is discontinued, especially regarding late relapses.
How long is the follow-up typically in these studies?
Often relatively short. For example, the median follow-up time in the large UK cohort was only 80 days. That gives us great information on the acute treatment period or shortly after, but not years later.
So we don't know the very long-term impact yet.
Not definitively. While Caplacizumab dramatically improves acute outcomes by rapidly controlling thrombosis, its impact on the very long-term morbidities often seen after ATTP is still largely unknown. Survivors often describe persistent issues, things like neurocognitive impairment, brain fog, anxiety, depression, that profoundly impact their quality of life for years.
And the question is, does stopping the clots earlier help prevent those?
That's the critical question. Does Caplacizumab, by rapidly controlling that microvascular thrombosis in the acute phase and potentially limiting the duration or severity of organ ischemia, reduce these long-term morbidities? It's biologically plausible, certainly.
Seems like it could.
It does. But we need robust, extended clinical studies and prospective registries that actively track patients over many years, not just months, to accurately define these long-term health outcomes and definitively evaluate caplacizumab's full, enduring benefit. This is a really critical area for future research to understand the complete value of this therapy for you and your patients.
Definitely need that long-term perspective. What about specific patient groups, maybe those less represented in the initial trials, like children or pregnant patients? Are these real-world studies shedding any light there? And how are diagnostic scores, like the plasmic score, being integrated into real-world clinical decision-making, especially when rapid ADAMT13 results aren't immediately available?
Good questions. While most studies we've reviewed primarily focus on adult patients, some, like the UK cohort, did include a small number of pediatric patients, indicating that caplacizumab is being used in younger populations.
And does it seem effective there?
Well, the numbers are small in these specific cohorts, but other cited literature suggests it does show efficacy and safety in pediatric patients, similarly helping to reduce the need for PECs. But more systematic pediatric data would be valuable.
And pregnancy.
Data on pregnant patients is still quite sparse in these particular real-world studies. That remains an area that clearly requires more focused and dedicated investigation, given the complexities of managing ATTP in pregnancy.
Understandable. What about the diagnostic scores?
Yes, we are seeing the growing integration of tools like the plasmic score in real-world practice. German and Italian studies, for example, retrospectively applied the plasmic score to their cohorts. They noted its usefulness in helping guide those crucial early treatment decisions, initiating PECs and immunosuppression promptly, especially in settings where rapid ADAMTs13 testing might not be immediately available 24/7.
So using the score to justify starting treatment faster.
Exactly. It highlights how clinical scores can empower you, the clinician, to initiate potentially life-saving treatment based on a high probability before you have that definitive lab confirmation, particularly when every moment counts in preventing irreversible microvascular damage.
A practical tool for quick decisions.
Very much so.
Okay, finally, looking at the bigger picture. How is caplacizumab changing the broader treatment algorithm for ATTP? Particularly thinking about its sequencing with rituximab, or maybe even enabling entirely new approaches that were perhaps unthinkable just a few years ago, like TPE-free treatment. Is this truly a paradigm shift in how ATTP is managed?
I think it's fair to say caplacizumab is clearly pushing the boundaries of how we approach and treat this disease. It's prompting reevaluation of established practices.
Like the timing of rituximab.
Exactly. We've already discussed seeing shifts towards earlier rituximab use in conjunction with caplacizumab. Some European centers are essentially adopting what's often being referred to as a triple therapy regimen as their standard frontline approach. That's PECs, steroids, caplacizumab, and early rituximab all together.
The full court press, immunologically speaking.
Pretty much. And remember, the potentially higher relapse or exacerbation rates seen in studies with less frontline rituximab utilization really seem to highlight the importance of tackling that autoimmune component aggressively and early, alongside the critical thrombosis inhibition that caplacizumab provides so effectively.
Give both a cause and effect simultaneously.
That seems to be the emerging strategy. And then you mentioned TPE-free treatment. That's the really intriguing, potentially paradigm-shifting concept on the horizon.
Is that actually happening?
Well, there's at least one Italian case report where they successfully treated a patient with caplacizumab and immunosuppression, but completely omitted PECs.
No plasma exchange at all.
None. This was possible because the patient had such a rapid and profound platelet recovery with caplacizumab plus immunosuppression alone. Now, obviously, this is currently anecdotal. It's a single case report. It absolutely requires rigorous validation in larger prospective trials before anyone considers it standard practice.
Of course, needs much more study.
Definitely. But it represents a truly significant potential innovation, suggesting that maybe for certain carefully selected patients with a very rapid response, PECs might eventually be de-escalated or perhaps even avoided entirely in the future. It truly illustrates the dynamic and rapidly evolving landscape of ATTP management in this era of targeted therapies.
Fascinating possibilities. So let's try to summarize. After this deep dive into caplacizumab in the real world, what are the main takeaways?
It certainly seems clear that this targeted therapy is having a profound impact on how we manage acute thrombotic thrombocytopenic purpura.
I think that's fair to say. Across these diverse real-world cohorts from different countries and healthcare systems, caplacizumab consistently demonstrates remarkable efficacy.
It clearly accelerates platelet recovery, often bringing counts back towards normal in just a few days, which is critical for stopping organ damage. This rapid response is one of the most consistent findings.
And the PEX reduction.
Yes, it also significantly reduces the need for prolonged plasma exchange sessions. That alleviates an immense burden on the patient and saves considerable healthcare resources. And importantly, it seems to play a crucial role in preventing those early exacerbations, which can drive further organ damage and prolong recovery.
And the safety.
While bleeding is certainly a known side effect consistent with its mechanism of action, the real-world data suggests it's generally manageable. Crucially, the risk of severe life-threatening bleeding doesn't appear to outweigh the substantial clinical benefits caplacizumab offers in this otherwise potentially fatal condition.
So a positive picture overall, it sounds like.
A very positive picture, particularly regarding acute outcomes.
It sounds like a truly transformative agent, especially maybe for specific patient profiles where time is absolutely the essence and the risk is high.
Absolutely. Caplacizumab seems to show its greatest benefit in the most vulnerable patients, those who present critically ill, those with significant organ involvement like cardiac or neurological symptoms, and perhaps individuals who are proving refractory to conventional treatments.
The sickest patients benefit most.
It seems so. Its rapid action provides that essential bridge. It protects the organs from ongoing microvascular thrombosis, effectively buying you critical time for the immunosuppressants to work and address the underlying autoimmunity. In a disease where every hour matters, that time can make all the difference, dramatically improving acute outcomes.
A crucial time buyer. Okay, this has been an incredibly insightful deep dive, really bringing the real-world data to life and offering practical knowledge for anyone navigating the complexities of ATTP. But as with any evolving field, there's always more to learn, always more questions. So what's a final provocative thought for our listener to mull over as they reflect on everything we've discussed today?
Okay, here's something to really think about, something that gets to the heart of translating these findings into practice. If this growing body of real-world data increasingly supports the profound acute benefits of caplacizumab, not just in terms of clinical efficacy like faster platelet recovery and fewer exacerbations, but also in significantly reducing the healthcare burden through fewer PEC sessions and shorter hospital stays, potentially even lowering overall costs.
Which the data seems to suggest.
Right. If all that is true, then how do we ethically and practically ensure equitable access to this therapy for every patient suspected of having ATTP?
Equitable access.
Yes. Regardless of their geographic location, the type of hospital they present to, or even their initial ADAM-TS13 results if clinical suspicion is high. This isn't just about getting regulatory approval anymore. It's about actively overcoming the very real logistical, financial, and educational barriers that currently exist in many places. How do we ensure this rapid response therapy reaches every single patient who could benefit, fundamentally changing the prognosis of this devastating disease across the board?
A challenge for the whole system.
It is. So the provocative question for you, the listener, is: what critical steps can you take within your own practice, your own hospital, or even your wider healthcare system to champion this early access and help make this potentially life-saving treatment a universal reality for patients diagnosed with ATTP?